Good. So with someone with post-renal factors, okay. So for the post-renal factors, I said that they are usually caused by obstruction, okay, like maybe kidney stones or how do you call it, cancers, okay, or even a blood clots, okay. Uh-huh. So for these ones, you have to deal with the underlying cause, okay. And if the person's urea and creatinine levels are astronomically high, then you can take the person for dialysis, okay, and they can remove or get rid of some of those waste products, okay. And you have to monitor the levels. Hyperkalemia, we talked about management of the hyperkalemia. We mentioned 6 ways of treating hyperkalemia. Who can mention one? Okay, so I'm sure we're all around. So I'll mention some names. If I mention your name, you give me one way of treating hyperkalemia. Okay. Yes. Okay. Let me start with Araba. Araba, please give us one way of treating. Hey, she has gone offline. Okay. Sandy. There's someone called Sandy. Sandy Irama. This part is going offline. Oh, please, who can give us one way of managing hyperkalemia?
IV.
Yes.
I just joined.
Yes.
You can give the calcium gluconate.
Please, can you speak up? I can't hear you well.
I said you can give the calcium gluconate.
I can't hear.
The calcium gluconate.
Good, calcium gluconate. And what did I say was the function of calcium gluconate?
You said it protects the cardiac cells.
That's what?
It protects the cardiac cells.
Yes, good. So it stabilizes the myocardial tissue. Good. Okay. Who else will give us one way of treating hyperkalemia? Okay, you let me go down and see. Okay, okay. Zara, you are there. So Zara, give us one way.
Dialysis.
Good, dialysis. Okay, but remember, dialysis is for late. It's at late stage. Okay, but it's also parts. Okay, who else? You can look in a slide. There's one over here. Okay, I said you can give the person insulin and glucose. Okay, because insulin can shift the potassium into the cells. Okay, so we've looked at calcium gluconate, which should be the first thing you give. 10 mL of 10% calcium gluconate in 1 minute. Okay, the rules of 10. Then you give the person glucose and insulin. Then you can nebulize the person with salbutamol. Salbutamol nebulization, okay? Then you can use ion exchange, resonium. We saw resonium, the ion exchange, okay? Then we talked about what else? I've left one. Okay, dialysis. Yeah, we looked at dialysis, and then finally we said the seat one was renal transplant for severe state. Okay, good. You said okay, good. So you've looked at all these things, and we've looked at the 3 phases of recovery: the oliguric phase, diuretic phase, and then the recovery phase. Okay, good. Now let's go to the most important part of today's session: chronic renal failure. Now we are not going to talk about everything. We are only going to look at the pathophysiology. Okay, that's what this concept's about. You see, if you understand this very well, clinical, yes, you won't suffer. Okay, I'm saying this, but well, good. So when you talk about chronic renal failure, okay, technically we say that someone whose kidneys have failed for more than 3 months, okay, 3 months. You notice that for most organ failures, we use 6 months. So like chronic liver failure or chronic liver disease, usually 6 months, okay. But when it comes to the kidney, we use 3 months. Good. So there are classification or classes of chronic renal failure, depending on the GFR, depending on the GFR. Okay, so we can group them in stage 1, stage 2, stage 3, stage 4, and stage 5. Stage 5 is we call it the end stage renal failure. End stage. At that stage, you need a new kidney. Okay, or you have to be doing dialysis every week. Maybe they say 3 times a week. Good. So, what are the causes of chronic renal failure? Anything that can cause acute kidney injuries can cause chronic renal failure. So, as I said, if you don't manage acute kidney injuries very well, the kidney can get damaged. Okay, it can get damaged irreversibly, and you go into chronic renal disease or chronic renal failure. Remember that we also don't like saying chronic renal failure. Okay, currently we say chronic kidney disease, CKD, okay, instead of chronic renal failure. Okay, so use the term well, chronic kidney disease. Okay, because in the early uh, in the earlier stages, okay, stage 1 and stage 2, the kidney is still functioning, but just that it's at a reduced rate, so it has not failed totally. Okay, so that's why we don't like using the term chronic renal failure, but you want to use the term chronic kidney disease. Okay, though it's irreversible. Okay, good. But there are some common causes of CKD, which is chronic kidney disease in our setting. Okay, and you should know the common ones. Okay, like hypertension, diabetes. Okay, they all cause CKD. So as I said, all the causes of acute kidney injuries can cause CKD. Okay, then you mentioned some special ones like diabetes, hypertension, and then polycystic kidney disease, which you guys did in pathology. Okay, all the glomerulonephritis can cause CKD, chronic kidney disease. So it's not difficult. Good. Now, how do they present? You see, the presentation of chronic kidney disease is myriad, okay? It's a lot. It can affect every system. It's going to affect every system, and its effect on the systems is based on the fact that there is high urea level. So urea is going to do all this damage, okay? So you'll be hearing a term like uremia, okay? Uremia, okay? And when you talk about uremia, a lot of people think that it means that you have high urea in your blood, okay? But it's not so. Uremia is the clinical presentation caused by CKD. That is uremia. Okay, so uremia is a syndrome. It doesn't mean that you have urea in your blood. Okay, a lot of people think that that's uremia. Okay, so the excess urea in the blood can damage all the system. So if they ask you what are the complications of chronic kidney disease, just relax. Take all the systems one by one and then start talking. Okay, start giving, because it can affect all the systems. So let's start with the cardiovascular system. If you have kidney disease, you can get hypertension. So you see, hypertension can cause chronic kidney disease, and then chronic kidney disease can cause hypertension. So at times, if they come with hypertension, we don't know what's led to what. Okay, was it the chronic kidney disease that led to the hypertension, or was it the hypertension that led to the chronic kidney disease? Okay, so it can cause hypertension. It can also cause pericarditis. Okay, pericarditis. Okay, or from the uremia, it causes inflammation of the pericardium. Now, let me end that for the cardiovascular system. Okay, there are lots, but I'll just end there. Now, when you go to the CNS, it can cause a lot of things over there. It can cause someone to go into coma. It can cause seizures. It can cause a lot of things, muscle weaknesses. Okay, because of the hyperkalemia, it affects the muscles. Okay, good. Then you can take the GIT. The GIT, it can cause gastritis. Okay, what is called uremic gastritis. Okay, and then it can also cause nausea and vomiting and anorexia. Okay. Anorexia, just because it's a chronic, most of the chronic diseases cause anorexia. Okay, good. For the skin too, it can cause pruritus. The person will just be itching his or her skin. Okay, and then for the genitourinary, it can cause impotence and then nocturia. Okay, and then yes. So let me end with this part. Okay, for the clinical science. One major thing that occurs in CKD patients is what is called anemia. So they have anemia. There are about 6 or 7 reasons why someone with chronic liver disease will come with anemia. Okay, when you ask people to list reasons why CKD people have anemia, the first thing that they'll talk about is, oh, because the kidneys produce erythropoietin, and the kidney is failing, so it cannot produce erythropoietin, so it can cause anemia. Fine, that was good. Then the next thing that they'll talk about is that, oh, chronic kidney disease is a chronic disease, so it can cause anemia of chronic disease. It's also fine. Okay. And then the next thing is that chronic kidney disease, okay, as I said, they have gastritis, so they have bleeding. Okay, they bleed in their GIT, so they have hematemesis. They vomit blood and other stuff, so that one too affects them. Okay, and then someone too can say that the uremia can go into the bone marrow and then directly inhibit erythropoiesis. Okay, that one too is fine. Okay, someone too can say that they are prone to infections. Okay, and if you have infections, the infections, the bacteria will use up the ions. Okay, so it can also cause anemia. That one too is fine. Okay, someone too can say that because they'll be doing a lot of blood tests. Okay, someone with CKD, you always take blood sample to go and do this investigation. So the excessive blood test can also cause anemia in a CKD patient. Okay, it's fine. Another person too can say that the dialysis. Okay, if you do dialysis, to it can also cause anemia. So I've given you about 7 or so reasons why someone with chronic kidney disease can come with anemia. Good. So as I said, the whole pathophysiology is because of the failure of the renal function. Okay, so its impaired ability to regulate water and electrolytes. Okay, will cause electrolyte imbalances. Okay, and then I've talked about the hyperkalemia, and then the metabolic acidosis. Okay, remember that, as I said, if you have hyperkalemia, because of the shift between potassium and then hydrogen, okay, you are more likely to get metabolic acidosis. But there is also another reason why you get metabolic acidosis. I'll explain soon. Now, the anemia in CKD is normocytic normochronic anemia. And you know that if you have anemia of chronic disease, usually it's normocytic normochromic, okay? Now, the last part I'm going to talk about, which the slides emphasize, is what is called the renal osteodystrophy, which is how the chronic disease affects the skeletal system, okay? It's a very important point. Okay, so that's over here, okay? Good. Now, renal osteodystrophy. What is all these things? Now, remember we said that the kidneys function to activate vitamin D, okay? And vitamin D is for calcium reabsorption, okay? So if you have chronic kidney disease, your you have reduced levels of vitamin vitamin D, okay, activated vitamin D. And if you have reduced activated vitamin D, you have reduced calcium level, which is hypocalcemia. Now, later on, when we do the endocrine, you will see that if you have hypocalcemia, then the parathyroid hormones will come in. Okay, what the function of the parathyroid hormone is to go and activate the osteoclastic cells for them to break down the bone, okay, the mineral portion of the bone. Remember, the bone is calcium and hydroxyapatite, okay? So the calcium is usually calcium and phosphates. So when they break down the bone, they will release the calcium, okay, as well as they will also release the phosphates. So the whole idea is that because of the hypocalcemia, the parathyroid hormone is causing the bone to break down, to release calcium into the blood, okay? And if the bone breaks down, you are releasing both calcium ions and phosphate ions into the blood. And remember, these phosphate ions, they are usually acidic, okay? So that also adds to the metabolic acidosis. Okay, and remember these phosphate groups are unmeasured anions. So if they increase, you have an increased anion gap, okay? So that's the reason why over here we are seeing that we have a metabolic acidosis with raised anion gap. The anion gap, if you remember the concept of anion gap, as I explained in the other tutorial, okay? If you have phosphate groups, they are unmeasured ions, so they will cause an increase in the anion gap. Good. So then, now calcium has been released, so the body is fine. Okay. Then you use the calcium, and then now your body needs to, how do you call it? Produce calcium again. So you are always going to stimulate the parathyroid hormone. So with such patients, you notice that there is hypertrophy of their parathyroid hormone. It has become large because it's overfunctioning, okay? And then now they are breaking down more bones. They are producing a lot of calcium. Now remember, this calcium is going to accumulate in certain tissues, okay? What is called the what's the name? This metastatic calcification, okay? Because of the excess calcium. So there's going to be metastatic calcification. Now, when this calcium accumulates in tissues, it will once again lead to hypocalcemia. So there's an alternating, okay, spectrum between hypocalcemia, and when the hypocalcemia comes, the parathyroid hormone will produce the hormone to release more calcium. The excess calcium will go and accumulate in soft tissue. Then the process just keeps on happening like that, okay? So you realize that as all these things are happening, so let's go through this quickly. So someone is renal failure, they have reduced vitamin D activation. So calcitriol is activated vitamin D, so its level is reduced. If its level is reduced, there is reduced calcium absorption. If there is reduced calcium absorption from the GIT, there is reduced calcium level, hypocalcemia, which will cause the parathyroid hormone to be synthesized. What is the parathyroid hormone going to do? It's going to increase bone resorption or bone breakdown. Okay, and this bone breakdown is going to lead to the demineralization of the bone. This demineralization of the bone will send calcium into the blood as well as phosphate into the blood. and that phosphate is and that phosphate causes this, which is the metabolic acidosis with increased anion gap. Okay, and I talked about the metastatic calcification over here. Good. So this is the pathophysiology of renal osteodystrophy, which I think I've explained. Good. Proteinuria. We've already talked about proteinuria. Okay, so kindly sit down and then read through this. But let me just emphasize causes of proteinuria. So the cause of the proteinuria, okay, we can group it into three. Okay, the first one is what is called the overflow proteinuria. When you say overflow proteinuria, that means that you have excess proteins in your body and then the kidney is just filtering them out. Okay, so we see this in several conditions. Okay, one of them is if when you infuse someone with albumin, the person will get a lot of albumin, and you get albumin in the how do you call it, in the urine. And we mentioned Benz-Jones protein in multiple myeloma. And you also get amylase, urinary amylase, okay, in acute pancreatitis, if you remember from acute pancreatitis, okay, and hemoglobin as well. So these ones are overflow proteinuria. That means there is excess protein somewhere, and then the kidneys are just allowing them to pass. Good. And you also have the glomerular proteinuria, where in this case, the problem is with the glomerulus. The glomerulus is not supposed to allow proteins to be filtered, but in this case, they allow proteins to be filtered. Okay. Now, the cause of the glomerular proteinuria, okay, we have one of them which is normal, okay. For example, when you exercise or when you have fever or when you have congestive heart failure, okay, there is some proteinuria, okay. It doesn't mean that your glomerulus is not, there is a pathology with the glomerulus, okay. It's just, it just happens, okay. But we have conditions where there are pathologies with the glomerulus, okay. And so glomerulonephritis of all forms can cause proteinuria. Diabetes, hypertension, pregnancy, preeclampsia, eclampsia. I've talked about all this. They can all affect the glomerulus, okay. Good. And the third one is the tubular proteinuria. In this case, what is happening is that the tubules are secreting the proteins into the urine. So they are rather secreting certain proteins into the urine, okay. And then these are some of the causes. If you have acute tubular necrosis, okay, the tubules will undergo necrosis, and then they will release their proteins into the blood, okay. Good. And you also have what is called a post-renal proteinuria. This one is infections. If you have any infections in the urinary tract, okay, the protein levels in your urine will increase. Good. So this picture is just telling us about all that we talk about. So for the overflow, what's happening is that you have a lot of proteins produced somewhere, okay, and it comes into it's filtered out. Some are reabsorbed, but others come out through the urine, okay. You see, normally the urine that comes must be reabsorbed, so that the proteins that comes must be reabsorbed, so that there is no protein in the urine. Good. Here too, there's the glomerular cause. So here, there is normal small amount of protein coming, but the problem is the glomerulus. Okay, so the glomerulus is that which allows the protein to be filtered. Okay, some are reabsorbed, others to come out as urine. And here's the tubular cause. Okay, tubular cause. There's a problem with the tubule. It cannot absorb it, or the tubule itself is secreting proteins. Okay, remember this protein, phosphorus proteinuria. Okay, that's a protein produced by the renal tubules. Good. So as I said, you use a dipstick to measure this. I'll leave all these things for you guys to read. Okay, I've done a lot of work. I've mentioned most of the important ones. Okay, the last thing that I'll talk about is the nephrotic syndrome. Let me see how many slides. The renal stones too. I'll leave it for you guys to go and read. So, nephrotic syndrome. I'm sure you guys, you've done nephrotic syndrome. Okay, we have 10 minutes more to finish. So for nephrotic syndrome, okay, um, what's happening is that there is proteinuria. Okay, so because of this proteinuria, okay, you have a lot of protein in your urine, and you are losing a lot of protein in your urine, and because of that, the protein in your blood is low. So nephrotic syndrome is characterized by proteinuria, which is protein in your urine, and then hypoalbuminemia. So the albumin, which is a protein, okay, you have low levels of it in your blood. So hypoproteinemia. So you have proteinuria, hypoproteinemia. Okay, that means reduced levels of protein in your blood. Okay, and then because of that, you have generalized edema. Okay, that is nephrotic syndrome. Okay, so everything over here is explained. Now, what the last thing I'm going to emphasize here is that they don't only lose proteins. Okay, sometimes they lose immunoglobulins, which are the antibodies, and because of that, they are susceptible to infections. Okay, good. And then because they are losing a lot of proteins, the liver compensates by producing other proteins. Okay, and these proteins, uh, um, like fibrinogen, okay, so they can lead to a thrombotic tendency. Okay, thrombotic tendency. Good. And then it's also associated with hyperlipidemia because the liver also tries to compensate for the hypoproteinemia by producing a lot of lipids. So what can cause nephrotic? So glomerular changes like minimal change, okay, membranous. Now you see, let me give you this last hint for your renal pathology. Now you see all the glomerular nephritis that you guys learned, okay, there are a lot of them. They all give pictures, okay? So they can either give you a nephrotic picture or a nephritic picture. Okay, so the nephrotic picture is what I have described. So remember that minimal change will give a nephrotic picture. Membranous glomerulonephritis will give a nephrotic picture, okay? But there are some others too that can give nephritic picture. When you talk about nephritic picture, which is smoky urine, hypertension, hematuria, okay? So at the back of your mind, know that there are two pictures. If someone has glomerulonephritis, there are two clinical pictures. How do I see them? When they come, how do I see them? Okay, when they come, I can either see someone who has who is edematous, okay, and then the person's protein levels in the blood are low, and the person has high levels of protein in the urine. Okay, this picture is a nephrotic picture. Or the person has smoky urine, and then the person also has the person has smoky urine, or the person has hypertension, or the person has hematuria. Then I say, okay, no, this one is nephritic picture. Okay. So then what you do is that you now take biopsy of the person's kidneys. Okay. So it's when you take the biopsy of the person's kidney that's going to tell you whether it's minimal change, it's membranous, okay, or the other ones that you did, focal, segmental glomerulosclerosis, and all those things. Okay. So those ones come only when you take biopsy and you look under the light microscope or the electron microscope. So the pictures are two. Those ones is what you see the patients, okay? What you see, I mean, when the patient comes to you, it's either nephrotic or nephritic. Then when you go ahead and take the 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 biopsy, okay, what you are going to see is the histological classification, which could be minimal change, and then membranous, focal segmental glomerulosclerosis, the messenger proliferative, and all those kind of stuff. Okay, good. Let me see. There are some questions here. Okay, so let me see. There are some questions over here. Someone is asking, how does the uremia cause gastritis? Okay, so remember that the uremia is usually how do you call it? Is basic. Okay, it's basic. So there are two possibilities. The uremia itself, okay, that's the urea, high urea level, okay, can directly cause inflammation of the gastric mucosa, okay. And two, the urea levels too can reduce the or can increase the pH of the stomach, okay. You know, the stomach has a low pH or being acidic. The urea being basic can neutralize the acid, okay. And then if the acid is neutralized, bacteria can grow over there and cause inflammation, okay, causing gastritis, okay. So those are the two possibilities of uremic gastritis. Okay, so please, we are ending here. I've done most of the slides over here, okay. I've done most of the slides over here with you guys. Just as I said, after this, quickly go through this again, okay, and then you'll be fine. Any questions? Any questions?
No.
Please, any questions?
No.
Okay, good. So
No questions.
please, so today is Monday, okay. As I said, we will finish on Wednesday. So right now, what we have left is the endocrine part, okay. So we will start with the endocrine part of chem pathology tomorrow, okay. Then we end on Wednesday. Then I can wash my hands, okay. Then I know that I've handled most of the chem pathology with you guys, okay. Good. Any questions?
No.